Okay,
Okay.
got the message. All right, well, thank you so much. So I'm going to talk about behavioral symptoms in dementia today, and there will be a focus on some medications after we talk about it generally. Um, and so just as a disclaimer, I'm a part-time employee of the federal government, and I believe I'm supposed to let everybody know that my views about this do not represent the Veterans Health Administration, the Department of Defense, or the United States government. They're just my opinions. I have research funding through NIH, Alzheimer's Association, and do some CME related stuff that I've gotten honorarium for. And then the other thing to know is that almost everything I'm going to talk about today is off label. There are incredibly few FDA approved medications to target behavioral and psychological symptoms in dementia. Before we talk about behaviors, I always try to start these discussions with some common language that I'll be using and discuss MCI, dementia, some specific syndromes and behavioral symptoms. We're going to then talk about some of those syndromes, things like Alzheimer's disease and Lewy body dementia. And then we will talk about how medications can and often are part of the problem with behavioral problems. So that sometimes stopping medications may be what we need to do. We'll talk about what we can treat and how, when to think about getting help with behavioral symptoms, and then hopefully provide some practical advice of working with a care team to target and manage these types of symptoms. So anytime we're talking about a cognitive disorder, so a disorder of memory and thinking, I always describe this as a two-part diagnosis. The first part is a syndrome. We have to define what the problems look like. And I often use the metaphor of having a weak arm. So there's a lot, you could come into the doctor's office and say, my arm is weak, or my arm is weak and I'm having trouble using it. And that's kind of like saying mild cognitive impairment in dementia. You're just describing what's going on and how severe it is, but you're not talking about the cause or the etiology at that point. So your arm could be weak because you slept on it wrong and have a pinched nerve. It could be weak because you've had a stroke or because of ALS. And so it's really important to both describe what it is that we're talking about, but also think about the etiology. And I find that in practice, that second part of even getting to the etiology and what's causing it is something that doesn't always happen with clinicians who are taking care of cognitive disorders. So the first question that I have to answer is there an identifiable problem? And it's not that I don't believe people when they come in and say they're having changes in their memory. It's that I have to figure out, is this a change that is not part of normal aging? Because after about 25, many of our cognitive skills have a relative decline. So I certainly don't have the same cognitive skills that I had at 25, and I won't have the same cognitive skills at 60 as I have now. But those are normal changes. There are other things that don't change with aging, but certain speeded tasks and things that rely on complex attention, there's an expected decline with age. And so we have to figure out, is it more than that? Because the first change that we would get to is something called mild cognitive impairment. And this is sometimes not identified in clinical practice specifically because it doesn't cause problems in day-to-day life. It's something that may be noted. You may know there's a change. Spouses or children may notice a change, but you're still able to do all the tasks that you've always done. And in fact, that's a requirement for that diagnosis, is essentially intact daily activities. Now, mild cognitive impairment is a description. It's not a full diagnosis. So sometimes people might have mild cognitive impairment due to poorly treated sleep apnea and depression, and it could get better with identification of those causes. Sometimes it stays stable. It could be due to an old stroke or a traumatic brain injury, or we may not identify a clear cause, but mild cognitive impairment, just as a description, can either get better, stay the same, or then in about 50% of people, it does represent a prodromal stage prior to dementia. And so dementia is the term that we would use when there's both cognitive changes that we can measure, but now it causes problems in daily activities. And the first problems that we see are instrumental ADLs, things like driving, cooking, and cleaning. As dementia progresses into moderate severity, we see trouble with meeting one's physical needs, dressing, personal hygiene. And then finally, severe dementia would be the term that we use if somebody's fully dependent on another for all of their basic care. And so that's a description of the first part of a cognitive syndrome that we're dealing with. Next, we're going to talk about behaviors just a little bit. And then we're going to, after we talk about behaviors, we're going to talk about some specific syndromes, and then we'll move on to the treatment. So a behavior is just what we can observe and measure that others do. We all have behaviors. It's just external things that we do to get through the world. What we're really focusing on is not behaviors, but what might be called challenging behaviors. And these are, you can think of these as things that keep people from successfully participating in their daily life. And what is or isn't a problem can vary a little bit. It's important for me to understand the interaction between the person living with dementia and their caregivers and their support group. Because sometimes what's a challenging behavior for one person it may not be as challenging in another context. Behaviors serve a purpose and communicate a need sometimes. And these may not be needs that make sense in the context of their current environment, but sometimes they do. Pain, hunger, boredom, all of these things can generate a behavioral change. And I may be able to say, I'm kind of irritated because I've had a bad day and I'm bored, but somebody living with dementia may not be able to communicate that. And so the communication of those needs can really be impaired. I'm going to try to use the term behavioral symptoms. In the literature, you'll often see BPSD, or behavioral and psychological symptoms of dementia, or neuropsychiatric symptoms. Those are synonyms for this, so they really mean the same thing. When we talk about these symptoms, many of them are going to look pretty familiar to you, things that you will have encountered before. So we'll walk through these and sort of group them together. So if we start with these changes in emotional regulation, depression, anxiety, elation. So depression is a persistent, down, depressed hopelessness. One of the things that I see commonly is that folks will come in and they'll note that they have these symptoms, but they'll say, well, yeah, I get down for a day, or I'm grieving this new thing that I'm dealing with. And I'm careful to talk with folks about this, because a medication is not going to fix having a bad day. It's not going to fix feeling down. It's not going to fix grief in some instances. And so, often we won't use medications if that's the case. But if somebody's having persistently decreased mood that's really happening, every day for weeks at a time, that's when we talk about trying to target this. Anxiety can be a very episodic thing, and it may be something that people experience chronically, or it may be something that just happens every so often. This is an excessive feeling of being tense or nervous or being worried about things, having a sense of panic at times. And then elation. This is more seen in certain causes of dementia, but sometimes people appear to almost act or feel too good. They're excessively happy, talking really big and grandiose, almost sometimes even seeming childish. And that can be a real problem depending on the context. Apathy is a really common symptom that I see, and is a real problem for daily, just enjoying daily life. This is a decreased interest and motivation. It's very common for people to tell me that someone's depressed when they're actually apathetic, because it can look like depression, but the difference is there's no mood component if it's just apathy. It really is a disorder of motivation and interest. And so people will be less spontaneous, less interested, less likely to initiate conversations. And it can occur with depression. It's common to occur with depression, but it can occur without depression. And the reason that's an important distinction is because the medications that target depression can sometimes worsen apathy, and they're not, and the things that can help apathy are not treatments for depression sometimes. And so I try to distinguish between the two. There are these problems that you can sort of lump under impulse control. Agitation and aggression are really common, especially in more severe dementia. Agitation can be defined as an excessive motor activity, the pacing, walking around, can't sit still, can be an it can become verbal or physical aggression, resistance to care. Irritability, another very common thing. I see this a lot very early, before people even realize that they have a cognitive disorder. Often family members will say, they've been irritable, and can't cope with things as well. Their mood's all over the place. They're happy one minute and really angry the next. So that's a very common thing. And then motor behaviors can overlap a bit with agitation, sort of repetitive activities, handling buttons, wrapping string, pacing around without a purpose. There's disinhibition, socially inappropriate or impulsive acts, being too familiar with strangers. Sometimes this can manifest with people being prone to being taken advantage of by scam and fraud, making sensitive or hurtful remarks or talk about things that they would never have talked about in the past with strangers. Psychosis includes both delusions and hallucinations. And delusions are these fixed false beliefs, sometimes people stealing from them or planning to harm them in some way, misidentification of a spouse or a child, or fear of abandonment. And delusions can be very difficult to treat with medications. Hallucinations, these are perceiving things when there's nothing there to perceive. So hearing voices, talking to people that are not there, seeing, feeling, smelling things that are not there. They can range from simple, seeing a shadow out of the corner of one's eye, to complex, seeing children and animals out playing in the yard or in the house, or someone sitting on the couch, things like that. Occasionally, people will know they're not real, and it can range in spectrum from aware that it's not real and not even really a psychosis. It's a hallucinosis where there's this acknowledgement that that's not real, to completely convinced there's nothing you will ever say or do to convince that person that the thing they're seeing is not real. Because it is real to them. To their perception of their world, it seems just as real as sitting in this Zoom call seems to you right now. And that can be very difficult to deal with. Nighttime behaviors, this can be too much or too little sleep, it can be acting out dreams. And then appetite or eating can be too much, too little, a change in preferences. And all of these together represent the common neuropsychiatric behavioral symptoms. And so many of these will overlap. It's not your job to figure that out. It shouldn't be your job. All I really want caregivers, family to do is to help describe what's going on. And then it's my job to try to probe and ask questions to understand, well, is this really a delusion, or is this a false memory that someone is having? Are they anxious, or is it a motor agitation that doesn't have an emotional component? Is there apathy with or without depression? Those are things that I can try to discern and figure out. I do try to measure these by standardized questionnaires because it helps me keep track of things. This is the neuropsychiatric inventory. It's a really common one to use in dementia. Um, and so the way it works is there is a questionnaire that says, does the patient have false beliefs? And it describes them, such as thinking others are stealing from him or her, planning to harm him or her in some way. One of the challenges with this is that it can be tough for caregivers to fill out the first time. These are all symptoms that I'm very familiar with and can distinguish between, but sometimes they kind of bleed over and overlap. So it's important for me to occasionally ask clarifying questions. If somebody says, yes, there's a delusion, then I need to make sure I follow up and ask about that delusion and not just say, well, okay, they said yes, so it must be that. It asks caregivers to rate the severity, and that's how it affects the patient. Is it mild, moderate, or severe? And then just as importantly, it's how much distress is that symptom causing in you, the caregiver, the person filling out the form, because those are both really important features. And it's not adequate to just think about one and not the other. We know that behavioral symptoms are a much stronger predictor of caregiver distress and burden than the cognitive portions of the disease. Over half of symptoms reported are reported to be moderately to severely distressing. And that really, more than the presence of a symptom, is what predicts future placement outside of the home. And so it's important for me to know, is this a symptom that's there? And if so, how distressing is it? Because that can guide how urgently we need to try to target that symptom. And so like I said earlier, the same symptom can be present in two individuals, two caregiving dyads, and I may need to treat one more aggressively than the other, even though the symptom looks very similar. So it really does take sort of a biopsychosocial formulation to make sure that I'm considering these things appropriately. Very briefly, we're just going to talk about the different causes of dementia. And so Alzheimer's disease and vascular dementia are by far the two most common things out in the world. And their behavioral profiles can look fairly similar. Majority of individuals will experience a clinically significant behavioral symptom at a point in the course of the disease. And in the early stages, you tend to see more depression, anxiety, apathy, irritability, and agitation. And then later on is when you tend to see the psychosis, sleep and appetite changes, and then agitation becomes very common. Another way to show this is this is a graph looking at the frequency of symptoms and in relationship to the time of diagnosis. And so cross-sectionally, over half of individuals with Alzheimer's disease, even with MCI, will have behavioral symptoms, and it's associated with caregiver stress and long-term care placement. So if you look here, this 0 is sort of when someone's diagnosed, and so if you look to the left, you see these things that people identify before a diagnosis was made. And we know from other studies that behavioral symptoms frequently predate the emergence of clear memory and cognitive symptoms. And so you see social withdrawal, depression, paranoia, anxiety, even things like suicidal ideation that can emerge years sometimes before the onset of symptoms that would lead to a diagnosis. And you can see agitation and aggression agitation is by far the most commonly experienced symptom. And then aggression is related to agitation. It's less common and tends to occur in more severe cases. And so we'll end up talking about many of these symptoms specifically, even some of the ones that can be really challenging to even talk about with your clinician. Things like sexually inappropriate behavior, wandering. These are really tough behaviors, but really important to know about and be able to manage. As I said, there's really no FDA-approved medications for most of these. The exception is pimavanserin, very specifically and limited to Parkinson's disease psychosis, and brexapiprazole for agitation and Alzheimer's disease. Those are the only ones that are FDA approved, and they are prohibitively costly in many instances, and just not easy to use because of that. Lewy body dementias are the second most common neurodegenerative cause of dementia. Terminology here is really confusing. So just in general, Lewy body disease refers to Parkinson's disease and Lewy body dementia. Lewy body dementia, it really is sort of this supraordinate category that describes to two more specific diagnoses that depends on when the Parkinsonism or movement changes occurred. If they occurred within a year, or if the dementia occurs first or within a year of the onset of Parkinsonism, we call that dementia with Lewy bodies. If the dementia occurs in the context of well-established Parkinson's disease, we call that Parkinson's disease dementia, and they are both technically Lewy body dementia. Behavioral presentations here are common and it's earlier. Hallucinations, delusions, anxiety, sleep irritability, and apathy are all very common. Frontotemporal dementia, there are three different variants, but I'm going to lump the language variants sort of together. They're very different in terms of the language problems, but for the purposes of behavior, I'm just going to lump them and say there are language variants. Less prominent behavioral changes there, though they do happen, especially later in the disease. In the behavioral variant of frontotemporal dementia, you see things like loss of sympathy and empathy, apathy, craving of especially carbs and sweets, ritualistic compulsive behaviors, and socially inappropriate behavior. So that's really the one that's most relevant for behavioral symptoms. Much more challenging behaviors early on. Apathy is very common. One of the challenges, though, is that apathy is common, but one of the situations that you can get into is that treating apathy, sometimes it's the apathy that's preventing people from engaging in problematic, socially inappropriate behaviors. And so I've had individuals where we sort of thought that treating the apathy was a good idea. And then once we treat the apathy, caregivers will sort of, call back and say, we got to stop that. We got to stop that medicine. It was better before. And so I need to be willing to sort of meet folks where they're at and try to understand the effects that we're having on behavior overall and be able to shift course after we start treating. Appetite changes, disinhibition are really common. Psychosis is less common, but it does occur in FTD. And really, we always talk about DLB, or Lewy body dementias, where psychosis is common. And that's true, but even visual hallucinations, which people think are sort of diagnostic for Lewy body dementias, I have patients who have Alzheimer's disease who have early hallucinations. So there's really no such thing as a completely perfect diagnostic sign, and so psychosis can occur across the spectrum of these diseases. One of the first questions that we have to answer is do we treat this? Sometimes things are not harmful, they're infrequent, people can be redirected pretty easy, and it doesn't really cause distress, and in that case, we probably shouldn't treat it. Medications may not be effective for the symptom that we're talking about. An example is, we think about verbal aggression, there's a lot of reasons people could be verbally aggressive. If it's pain, psychosis, or depression related, then those are important. We can try to treat those. But if it's due to somebody, feeling bored or powerlessness or being overstimulated or having unmet care needs, medication is probably not going to do much for that. And this can be really tough to figure out what's what's beneath the behaviors. Safety is really important. If somebody calls me and says, you know, they're throwing things at me, they're trying to hit me, then we have to treat that more aggressively. We have to really try to get out in front of that. I always consider physical causes, especially when the changes are sudden. So when I've got somebody who calls me, they've never had aggression before, and all of a sudden they're confused and aggressive, we're not going to start with medications there. We really need to think about infection, pain, sensory problems. Are they not sleeping well? Were new medications added that seemed to correspond with this before we start just treating with drugs. Anticholinergic medications are the biggest offenders that we see that can be associated with worsening of cognitive and behavioral symptoms. The list is huge, and I'm going to go through a couple of these, but all of these medicines here, some of them exceedingly common, available over the counter, are anticholinergic and can cause worsening of symptoms. So we'll go through these classes in just a moment. Sometimes the benefits of those meds outweigh the harms, but it at least needs to be considered. So this is, I can't give a talk without having a brain somewhere. And so this is the cholinergic system in the brain. And the only thing that's important to really know here is these structures here in the basal forebrain project everywhere. And so they project all out to areas of the cortex. And so medicines that reduce the ability of this system to function normally can really have widespread global effects on cognition. So this is really why anticholinergic medicines can cause significant problems. So we look at each of these groups. If you think about, antihistamines, allergy, cold and cough medicines, diphenhydramine is everywhere. It's Benadryl. This is in any of your over-the-counter sleep aids. Often have this in there. It's a real problem. Can definitely cause problems with confusion. Right below that, Vistaril or Atarax, which is hydroxyzine, is occasionally prescribed for anxiety. And somebody who's 40 without cognitive impairments, it might be a good choice for anxiety. It's not a good choice for individuals with dementia. And so we'll often stop that medication when folks come in on it. Bladder medicines, big common problem in older adults. Oxybutynin is a particularly bad offender that I see a lot, and we often try to get folks off of that medicine because it can worsen memory and thinking and behavior. Insomnia and sleep, you see again, diphenhydramine and doxylamine are really common in these over-the-counter sleep aids. Antipsychotics, now many of the antipsychotics we use have some anticholinergic properties. And so it is a balance with which ones we're using and which ones we try to avoid. And most of the antipsychotics we use are not on this list. We occasionally use some of them, but mostly we avoid these. Motion sickness is another big one. If people get vertigo, they get dizzy, and sort of easy to just, well, okay, you take some Dramamine or some meclizine, and those have anticholinergic properties as well. So just sort of some worst offenders that I see: Benadryl, NyQuil, anything with PM in the title, over the counter. There's just better options. Trazodone for sleep, Claritin for allergies. And trazodone's not the only option for sleep. There are other ones that I use. Benzodiazepines, I try to avoid in most cases. I'd rather use things like Buspar or an SSRI for anxiety. Oxybutynin, we may switch that to Myrbetriq, or I would talk to their PCP about switching it to Myrbetriq. For vertigo, these drugs don't work great anyway, so try to get folks some vestibular rehab. Occasionally, I have patients that say, I don't use it very much, and it really helps when I do. That's okay. All of these we can make exceptions for. For antidepressants, Paxil is a bad offender, paroxetine. It's a common SSRI, but it's not great to use in older adults. Muscle relaxers all have some problems. Heat, physical therapy, hopefully that will work. Do I have patients that are on muscle relaxers? Yes. They might have really bad back pain. And it's so what I tell patients is that needing it doesn't mean it may not be a problem. It still may be a problem, but it being a problem doesn't mean that you don't need it, right? So sometimes it's just important to recognize that this is a drug that could be impacting your cognition a bit, but you feel worse without it. So we're accepting that risk as it is. Hycosamine and dicyclamine for sort of stomach cramps, not great in folks with cognitive impairment as well. And so trying to do a better bowel regimen, make sure people are not getting constipated, is a better option when we can use it. Just a word on benzodiazepines and Ambien. They're almost always a bad idea. Increased falls, cognition gets worse, increased risk for pneumonia. But there's exceptions for every rule. If somebody has such crippling anxiety and panic that it's destroying their quality of life, I mean, then from a palliative standpoint, I think it's very appropriate to consider use of a benzodiazepine. People who have severe REM sleep behavior disorder often need clonazepam, which is a benzodiazepine. And then if people are on these chronically, it can take a long time to get off. I mean, I've had to titrate folks off over 6 months because if you stop them too quickly, it will cause folks to have rebound anxiety. Just to show one of the reasons why benzodiazepines are cause the symptoms that they do, it acts on the same receptor as alcohol does, and so it can cause similar effects to people having a few shots of alcohol, and so that's where you see the sedating effects, and sometimes it can worsen impulsivity and things like that. So approach to treatment: first, I think about safety, determine do we need to treat. Second, I think about reversible causes. Third, I think about non-medication options. And fourth, I think about medications. Sometimes that depends on the diagnosis. Lewy body dementia and frontotemporal dementia have some particularly important considerations. But often the management is predicated on the symptoms that are present. So I've got a couple of ways of looking at this. The first, I'm just going to look at drug classes and how they relate to treating different symptoms. And then I'm going to show a chart with symptoms and the drugs that we use. So antidepressants, these are things like SSRIs or related, these SNRIs. They can be helpful for agitation. They can be helpful for depression, for anxiety, and apathy when it's one of these. So the sertraline, citalopram, escitalopram, they don't really help with apathy, but sometimes venlafaxine or bupropion can help with apathy. Antipsychotics, now these all have a black box warning that they increase the risk of cardiovascular events and death in people with dementia. I tell patients that is the case. These are palliative treatments. They have very real risks and side effects, but for some of the symptoms we're treating, if it's effective, that theoretical risk is worth assuming. But it is important for people to know that they are not without risk. Here, these are sort of the four that you see used frequently. In Lewy body dementia, I really only use quetiapine or Seroquel. Pimavanserin is hard to get covered, so you're really limited in Lewy body dementia. This can be helpful for psychosis, although importantly, sometimes you don't fix the psychosis, but you may make someone less agitated while they have psychosis. And so that may be the treatment effect. Psychosis and aggression are the two big ones, though. If people are really physically aggressive, I'm often going straight to these because they're going to work quickest. I don't use them as much for anxiety. they have a role in anxious depression in people without dementia, but often these are not what I'm using for anxiety, unless that anxiety is so bad that it's leading to agitation and it's associated with psychosis that's driving the anxiety. Cholinesterase inhibitors, these are your donepezil, rivastigmine, and galantamine. They are really helpful for psychosis in Lewy body dementia, and I do not use these drugs in frontotemporal dementia because they can worsen behaviors. They can help with depression, often with an SSRI, and they can sometimes help improve apathy. And so, these are relatively safe drugs. So, especially in Lewy body dementias, and then in Alzheimer's disease or in vascular dementia, I'm going to try these drugs pretty early. Trazodone and mirtazapine are old antidepressants that aren't used very often for primary treatments of depression because they cause sleepiness. So turns out they're really good for insomnia and sleep difficulties. Melatonin as well can help with insomnia and circadian rhythm disorders and REM behavior disorder at particularly high doses. Namenda. So this is memantine. This is the drug that's FDA approved for Alzheimer's disease at the moderate to severe stages. So it's approved for cognition, just like the cholinesterase inhibitors. The reason they were approved has nothing to do with their effects on behaviors, but Namenda globally can sometimes help to improve behavioral symptoms in Lewy body dementia and Alzheimer's disease. It doesn't seem to do anything in frontotemporal dementia, and so I don't use it there. My hope is that in some instances we may be able to reduce the escalation of more dangerous drugs like the antipsychotics. And finally, benzodiazepines, occasionally with insomnia and REM behavior disorder and really, really bad anxiety. The stimulants, methylphenidate and modafinil are really the only two that I use very often. It can sometimes help with depression in adjunct with an SSRI, and it can treat apathy. There was a trial couple years back that showed that it did improve apathy scores in Alzheimer's disease. There was, in the same month, there was a trial that showed that it increased the risk of cardiovascular events within the first 30 days of initiating the treatment. Those completely separate trials. In the apathy trial, there were no major side effects, but another study looked at the use of stimulants in older adults and did find evidence of an increase in cardiovascular events. So again, this is a palliative question. Is improving the apathy worth assuming a little bit of risk for an increase in risk for cardiovascular events? And sometimes the answer is yes. Sometimes the answer is no. And then in Lewy body dementia, specifically, really bad daytime somnolence that we can't find another cause for can sometimes be treated with stimulants. So that was sort of looking at the class of the drugs and what we use them for. This is a table from a practical neurology article that sort of looks at, well, what do we use for treatment of psychosis, agitation, apathy, and sleep? And here you can see essentially the same information that we just talked about with a couple of exceptions. So for agitation, I mentioned SSRIs and antipsychotics. I didn't mention this dextromethorphan quinidine, which is it's one of these. It's a drug that's approved for use in pathological laughing and crying or pseudobulbar affect. It's called Nuedexta. It's often expensive and difficult to get approved for agitation, so that's very low on my list. Prazosin is a medicine that can sometimes help. I find it more helpful in my veterans that I'm treating who may have comorbid PTSD. and have a really overactive sympathetic nervous system. And then there's ongoing research on cannabidiol, CBD, and even THC, looking at can we target agitation with effectively pharmaceutical grade marijuana, active chemicals from marijuana. And then for sleep, I mentioned trazodone, the zolpidem, which is Ambien. I try to avoid the Z drugs, and I tend more towards trazodone, mirtazapine, or if I can get it covered, suvorexant. Sometimes difficult to get covered. So different ways of thinking about it in terms of what symptom are you trying to treat, and then what symptoms do the different classes of drugs treat. So I'm going to now talk about a couple of common specific instances and how I might think through the medications that are available. So this is from a very nice drug algorithm from a geriatric psychiatry practice in Toronto, University of Toronto. And this was done in individuals who were institutionalized in the equivalent of a nursing home. And so what they did was, and they did this in a very sort of, study way of they would often get people off of any drugs they were on before, try to start from scratch. What they said was they never really stopped the Alzheimer's treatments. And this was specifically for Alzheimer's disease and mixed dementia. It's not for frontotemporal dementia. It's not for Lewy body dementia. If people have been stable on a cholinesterase inhibitor and memantine, that drug is probably not the problem. It's probably not causing an issue, and so they favor keeping folks on it. I tend to as well. As needed drugs for agitation, while they're trying to come up with a good chronic plan, they'll use trazodone or Ativan. And then their main pathway, and again, this is not for Lewy body dementia, but they started with risperidone. And then if an adequate trial of that failed, they would move to either aripiprazole or quetiapine, which is another antipsychotic. These are both antipsychotics. And then they would move down the line. And carbamazepine is an anti-seizure drug that has some evidence. Citalopram is a antidepressant. Gabapentin, which is used frequently in behavioral management, and it sort of seems to have non-specific effects that may reduce some anxiety, may reduce agitation. Prazosin, or believe it or not, even after combinations fail, electroconvulsive therapy can be really, really effective in resistant cases of agitation and aggression. And I have colleagues who run geriatric psychiatry units who have found this to be sometimes the only thing that can keep people out of a psychiatric hospital, is maintenance electroconvulsive therapy. And just down here, they sort of discuss each of these drugs in terms of how effective are they, how quick are they, how tolerated are they, how easy to use are they, right? And so risperidone is probably the most effective drug that we have in Alzheimer's disease for agitation. The risks, of course, are, the tolerability is not as good. And so it can cause more Parkinsonism. It can cause people to have drops in their blood pressure. And so, none of these come without risks. It's always a risk potential benefit balance. So wandering and sundowning are, I think, two really common things that come up that I often don't see addressed specifically as well as I've seen in this article. And so this is another article from a publication called Practical Neurology, which is exactly what it says. It's very practical articles. And so this was published a couple of years ago, and it's not new research. It's written for practicing neurologists or other clinicians as sort of a review and synthesis of the literature, and often providing how we do this. And so Wandering is a really complex behavior, right? This is a multifaceted thing, but it's defined by what we observe, right? And so it's wandering is uh, it can be in place, so people can sort of pace around, wander within a house. It can overlap with other behaviors. A term that's been used more recently is critical wandering or elopement. This can be deadly. 20% mortality rate, and it's among the most dangerous behaviors that people living with dementia can have. And the reason for that is, if people wander away from home or an institution, I'm aware of patients who have wandered into a swimming pool and drowned, or wandered away during the winter, and the elements were they died from being out in the elements. And so this is a really, really critical, dangerous behavior. And so the first question that I'm sort of asking is, like, has someone ever wandered away from home or gotten lost while in public? And if the answer is no to that, I will ask some things that help me assess how at risk they are. So, do they become nervous and jittery in public? Do they want to go home when they're already at home? Do they seem disoriented in their home? Do they think they still work outside of the home, or ask where family members are? And you can see how those things would really prompt someone to try to, if they think they need to go to work, a normal behavior is to try to go to work. And it doesn't help to say, well, you don't have to go to work, because you won't resolve it that way. So they are at significant risk for wandering. The more severe the dementia, the more increased the risk is. First step is a safety plan. Notify neighbors, keep a list of places that they are likely to wander to. Have a recent photo available. You don't want to give someone a 10-year-old photo. You want to know, you want folks to know what they look like now. Make locks inaccessible, but it's really important. A lot of folks want to, they'll sort of lock from the outside. It's very dangerous to lock someone in a room when no one is at home, because if a fire were to happen, they would be trapped inside a home. So we do not recommend that people lock the door from the outside so that someone can't get out if no one's there. And if they wander away, immediately search in the direction of their dominant hand, right? So if you out the front door, if they're right-handed, start to the right, 1.5 miles. Call 911 immediately if you've determined they're missing. Do not wait. I would much rather you call 911 and then in 15 minutes go, oh, great, false alarm. That is far preferable to waiting an hour to call. So that's a safety plan. The other features of this that can be helpful is optimizing and maximizing those cognitively enhancing medications. I don't often go to 20 milligrams of donepezil unless somebody has Lewy body dementia, but it's not a bad idea to try to maximize those medicines. Again, this is not a cure-all, but you want to lower the risk as much as possible. And then understanding what is this how severe and how severe is the cognition and behavior in this individual. So somebody who has higher cognition and lower neuropsychiatric or behavioral symptoms, maintain supervision in unfamiliar places, maybe passive monitoring. Have an Apple Watch on, or a Fitbit that you can track, or even just a smartphone. Somebody who has more severely impaired cognition with lower neuropsychiatric symptoms, you're thinking about an adult daycare program, a companionship program, exercise programs if possible. If they have low behavioral symptoms, folks that have very high behavioral symptoms, so this would be like an NPIQ score of greater than 3. We're going to move on to the next slide to sort of talk about what do you do to try to address this. And it's really ruling out medical illness, intoxication, delirium. And then if that's not there, treat those neuropsychiatric symptoms. And so, sorry, that's not the next slide. The next slide is moving on to sundowning. Just saying, for high neuropsychiatric symptoms, like we talked about in the previous slides, I would be trying to treat those more aggressively if they have elevated symptoms. And the other thing to mention is there are these safe return programs. So like the home alert things that people can wear, some of them have a cost associated with them. You can try to reach out to the sheriff's department in your home county. Occasionally, they have programs and wearable GPS trackers that they have available for people at risk of wandering. Moving along to sundowning, another very common problem that I don't see addressed nearly as thoughtfully as I have in this review is so sundowning is onset and or worsening of behavioral symptoms in the early evening. It is more likely to occur in moderate or worse dementia and more common in the autumn and winter. It's multifactorial in what causes it. It has a lot to do with circadian rhythm. There's this, here it is. So there's this progressively lowered stress threshold model that, you know, throughout the day, we're all building up this sort of pressure in our brain to be more tired. It tends to occur in the day when there's increased pain, hunger, fatigue. And at some point, we all cross our thresholds of how well we can cope. And people living with dementia have a lower threshold. And the more severe the dementia is, the lower that threshold is. The risk is much higher when sleep is disrupted, when sunlight exposure is not adequate, when the routine gets disrupted, and then anticholinergic medications can make it worse. And so that's one of the first things I'm trying to do is minimize those anticholinergic medications. Trying to increase regular exercise early in the day, light exposure early in the day, trying to do things behaviorally that will promote people sort of calming down and resting, familiar music an hour before folks would sundown, eliminating those bad anticholinergic drugs. One of the problems that I think I have as a clinician is that by the time people come to me, we're beyond the familiar music phase, right? Like that, it's often sort of people are at a crisis when they come in to see me, and so we are often dealing with, you know, we've got to move beyond that at that stage, but they're still important to do. However, what I end up doing a lot of is optimizing the cholinergic medications, both in timing and dose. And so what I want to do is think about how quickly these medications get in the system. And so donepezil, I always tell people to take in the morning. I've had folks that start sundowning around, 4 or 5 o'clock. And so we may move that up until noon to try to really maximize the benefits that we're getting from there, from those drugs. If that does not work, I've taken to trying melatonin to help try to regulate the circadian rhythm. And I've had at least 1 or 2 cases where this was actually effective. And using doses of melatonin that are just simply look too high to most doctors. Generally, melatonin, if I were to take melatonin for sleep, I might take 1 or 2 milligrams, and that would be it. If I'm treating REM sleep behavior disorder, I titrate to 12 to 18 milligrams. Here, they recommend using 10 milligrams at night, and then going up 10 milligrams per week to a maximum of 30 milligrams. 30 milligrams is a very high dose of melatonin, and it has potential risks with it. It can cause In some instances, it's caused sleep disruption or nightmares or worse agitation. But I've had at least one or two folks that 20 to 30 milligrams of melatonin really did seem to help with the sundowning behaviors. And then finally, I'm sort of focused on what are the symptoms that we're trying to target. Are they sundowning and getting really anxious? Well, then you treat the anxiety. If they're sundowning and getting agitated without anxiety, I may focus on agitation, psychosis, similar. This is all prevention, trying to prevent it. When you're in the episodes of sundowning, first episode, it just looks like delirium. First episode is not something that you can identify is sundowning when it first happens. It takes a little while, because if somebody suddenly has behavior changes, I don't really know is that due to a urinary tract infection, pneumonia, electrolyte disturbances. So folks usually do need to see their primary doctor the first time this happens to get a basic medical workup done. Once we've established that, nope, this is just a thing that's happening most days, it's not due to something other than the timing of the day, then we sort of work on, can we do something to make the environment quiet, well lit? Does aromatherapy or music therapy help? And then if it doesn't, we are initiating some of those drugs that we would use in the instances of agitation. So I might use trazodone or risperidone or things like that acutely to try to target the sundowning symptoms. Somebody asked if I would make slides available, and certainly, yes, I'm happy to share I can share a PDF of the slides for folks with all this on there. The next thing to talk about that is sometimes under discussed with clinicians, because it can be embarrassing for folks to talk about. But sexually inappropriate behavior is something that does come up, and caregivers talk to me about this. And there's two types. There's intimacy-seeking behavior, and there's disinhibited sexually inappropriate behavior. And it can be tough, especially in residential care. How do you, that should say ethical balance, but there's an ethical balance of this, right? Seeking intimacy is not an abnormal thing. It's not unusual for humans to want intimacy. This has come up before with things like masturbation, right? So people will come to me very distressed that their loved one is engaging in masturbation, but you probably shouldn't seek to treat that as long as they are in their room in private and things like that. So it can be a balance. It would be, I think, ethically, I would not be comfortable giving somebody a medication simply to reduce, they chose to masturbate. But if they are doing it in the middle of the common room, that is something that needs to be targeted. So it's a balance, and it's often a tough discussion to have with folks, because again, some of these behaviors are things that may be new to children, having to sort of discuss these types of things about their adult parents, and so this is a tough one to deal with and to talk about. So the first thing that we try to do is redirect people. Sometimes you can have clothes that open in the back instead of the front if there are problems with disrobing. Providing alternate activities, providing appropriate avenues for sexual behaviors, such as, it's okay in your room, other people can't be, things like that can sometimes do the trick. If it's truly disinhibited, inappropriate in both context and behavior, then and those non-pharmacologic strategies haven't worked, then we start to think about, what do we need to treat? And so then I'm trying to understand, what is the behavior associated with it? Is it associated with psychosis, obsessions, mania, or confusion? Very rarely, I think once in my career so far, I've had a patient who ended up receiving anti-androgen therapy to reduce really inappropriate disinhibited sexual behaviors in a facility, and it came down to, you know, this person is going to lose their ability to receive care in a facility, and those are just real world considerations that you can't ignore. And then there are other medications, beta blockers, non-hormonal drugs, et cetera, that can be tried down the list. So how can we, meaning the medical community, help, or when can we help? To me, it's when the symptoms are disruptive and you feel like you're needing help. And so I try to have an open dialogue with my patients about, you know, when I ask folks, what can I do for them today when they come in for follow-up, you know, that's the goal, is to figure out what symptoms are present that are most bothersome. And somebody may tell me 2 symptoms that I can do nothing about and 1 that I can help with. But I've got to understand what the symptoms are to know whether it's something I'm able to help with. Monitoring response is important, depends on the medication and the behavior. We rely on a lot of data outside of those with dementia. And so for depression, you know, it takes 6 to 8 weeks to assess efficacy of an SSRI in individuals who don't have dementia. We don't really have a lot of trials of dementia in people, a lot of trials of antidepressants in people with dementia. At this point, the gold standard is basically me asking you, how's it going? You know, I use scales to try to make that semi-quantifiable, but at the end of the day, the way I assess depression and behavioral outcomes is really just asking you, how are things going? Partnering with clinicians is important, and this can be really tough because a lot of practices where people go to receive care for dementia are not set up to do this type of more intensive communication. One of the hopes that I have is that in many institutions, there is, folks may have heard of the GUIDE program, but it's this new CMS initiative where centers like Wake Forest, for instance, will get a particular amount of money for each traditional Medicare beneficiary enrolled in their GUIDE program, and that helps fund nurse navigators, more nurse practitioner support, things that we know are necessary for providing adequate dementia care that simply have not traditionally been funded very well, and so as an extension have not been provided as well. All of us know that the way dementia care services have been set up isn't ideal. I would love to have more support to have, ability to check in more frequently. There's a lot of inadequate constraints placed on care. And in some practices, I think it's important to even ask the person that you're seeing, are you willing and comfortable managing these types of symptoms? Because I've had some patients referred to me where their outside general neurologist basically said, yeah, I don't do that. I don't manage those symptoms. And I may not agree with that, but that is absolutely a view that will be espoused. And you should know if they're not willing to manage agitation, aggression, psychosis, then you need to know that. It's far better to know that and come up with get another referral somewhere than to try to go down the road of getting someone to manage something that they don't want to or know how to manage in the first place. And I know that's easier said than done. Importantly, so I cannot care for somebody with dementia without also caring for their loved ones. It's always thinking about the dyad. I've heard some colleagues refer to caregivers as a sort of a cognitive prosthetic. We are off. Patients with dementia are often offloading some of the things they can't do onto that person who's caring for them. And if I don't think about how that person's doing, I'm not doing the best I can for the person living with dementia. And so, caregiver distress is important to know. You got to put your own oxygen mask on first. For me, the canary in the coal mine is if caregivers are not sleeping. And this is one of the reasons that I may choose to be more aggressive with symptoms at night. Because if you're not sleeping, because they're not sleeping, then everything is going to get worse. And so I may choose to, we may have a conversation about, look, these meds have side effects, but like I need them to sleep because I need you to sleep because you have to be able to take care of them. Shared decision making is important. So I often tell my trainees when we're going into a room, I don't know what I'm going to do. And I don't mean that in that I don't have ideas, but I know what I think the options are, but that depends so much on, what the values, beliefs, what's important to someone sitting there in front of me. So it's always a conversation to understand. And then education is key. Sometimes I have to tell people, I'm sorry, I don't think I can help with that symptom. It's a bad symptom. It's frustrating. I don't think I can make that better. And then again, this is my approach. I recognize that I may be telling people an approach that is not always used in clinical practice. So I tell folks that this is educated trial and error. There's no cookbook to know exactly what to do first. I have very educated opinions on what I think is most likely to work, but if I try something and you tell me it doesn't work, okay, that's the answer. It doesn't work. And we may need to try something else. So I've found through my own family, when they sort of, tell me about, well, the doctor tried something for my shoulder pain and it didn't work, I'm not going back to him. Well, that's not the right thing to do. You got to give them another shot if they're willing to keep trying. And so I warn patients, like, we may try this and it may not work. So you just need to message me, let me know, and we'll try something else. I have done this through health portals. Patients can't come in every time the medication needs to be increased. So I will often give a titration plan and schedule, and we will communicate via the health portal or things like that, and making sure that people are being seen frequently enough. But again, if it's a bad symptom and it would take me 4 visits to get to the max dose of that drug, we can't wait a year to do that, right? So I would rather treat a little more aggressively at first and pull back to get symptoms under control. My approach is not everyone's approach, and so your mileage may vary, but I do think finding a way to effectively communicate is important. Even if it's just communicating and you hear back from a nurse who's talked to the doctor, that is at least something. And there's wind outside if people are hearing things hit my window. Okay, that is the end of my slides. So I'm going to stop sharing